You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from benchside to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast.
Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Stephanie Jardine, Oncology Clinical Specialist at ONS, and today we are joined by ONS member Jennifer Turcotte, Clinical Manager at New England Cancer Specialists in Scarborough, Maine, and member of the Southern Maine ONS Chapter to discuss safety considerations and what nurses need to know when administering a FOLFOX chemotherapy regimen. Jennifer wrote a two-part series for ONS Voice on what it takes to be an infusion nurse, which is linked in our episode notes. Thanks for joining me today, Jennifer.
Thank you, Stephanie. I'm very happy to be here.
To start us off, can you describe what FOLFOX is and its protocols for administration from pre-medication to at-home post-infusion care?
Sure. It's a great question. Thank you. So FOLFOX is a cancer infusion treatment using two types of chemotherapies in a 46-hour portable home infusion pump. It's a 14-day cycle. The total number of cycles depend on the type of cancer and the goal of treatment. FOLFOX is a moderate to high emetogenic risk, so pre-medications of antiemetics is required. Typical antiemetic combination would be a long-acting 5-HT3 antagonist, such as Aloxi, a corticosteroid, such as dexamethasone, and plus or minus an NK1 blocker, such as Amend. For the three infusion drugs, two chemotherapies, 5-FU, very common to oncology, is one of the most common chemotherapies used. It interferes with DNA synthesis. Leucovorin, which is not a chemotherapy, it's a form of a folic acid, is used to synthesize the efficacy of 5-FU. Oxaliplatinum is the second chemotherapy used in FOLFOX. It's an alkylating agent that binds to DNA and forms cross-links inhibiting DNA replication. In combination to those three, the patient would go home with an ambulatory pump, which I'll reference later, and that pump is filled with 5-FU, slowly infused over 46 hours. Typical FOLFOX administration would include a patient receiving their IV antiemetics. Then they will have a line, their IV line flushed with D5W, as oxaliplatinum is not compatible with normal saline. Pre-meds are followed by a 2-hour infusion of oxaliplatinum and leucovorin co-administered via a Y-site. These two drugs are compatible as long as both are prepared in D5W solution. Oxaliplatinum, again, cannot be mixed with normal saline. At the completion of the 2 hours of oxali and leucovorin, there's a 5-minute slow push of bolus of 5-FU. Following that 5-minute bolus of 5-FU, the patient is then connected to the ambulatory 46-hour home infusion pump. At the end of the 46 hours of infusion, the patient then, depending on what the institution policy is, may self-disconnect at home and bring the pump in the next time they have an office visit or next time they're due for treatment, or the patient will return to the clinic for pump de-access. Sometimes at that pump de-access, the patient will receive hydration and supportive care if they have had nausea, vomiting, diarrhea, and need some supportive hydration and antiemetics. Also, to note of FOLFOX, which is different than some of other chemotherapies, is that the patient needs to have a vascular access device placed because of being hooked up to the ambulatory pump. So this, such as a Metaport, would be placed prior to the start of treatment, and the patient would be properly educated on their vascular access device, again, prior to the start of their first cycle.
Well, I'm glad we're talking about this today because it sounds like it's a big protocol and a lot of things that a nurse and a new nurse to oncology would need to understand about this particular
Absolutely.
treatment.
Yes, absolutely.
So tell us, what cancers FOLFOX typically used to treat?
Sure. So FOLFOX actually is used to treat quite a few different malignancies, and especially for the new oncology nurse, FOLFOX is one of those treatments. If you're in a community setting, you're going to use FOLFOX a lot. It is used for GI malignancies, colorectal cancers, esophageal, GE junction, hepatocellular, and pancreatic, as well as gastric. So it treats a lot of cancers. It's used quite often as first-line treatment as well.
I have to say that FOLFOX has come a long way since I first gave it, all of the different diagnoses that it's used for now. So that's a great thing that it is being shown that it can be useful in all of those different diagnoses as well.
Absolutely.
So are there any patient populations that should avoid this treatment?
So there is one patient population that there should be serious consideration, and that would be a patient that has some cognitive impairment because they're going home with a 46-hour ambulatory pump that is infusing chemotherapy. So the provider and care team would really need to assess patients that have any kind of impairment, that they can be safe at home and that they can manage a pump at home. On occasion, the ambulatory pump may say occluded, or it may beep, or there may need to be a little bit of troubleshooting. So a patient and or caregiver would need to be able to know the proper protocol. And also, if there were the unfortunate incident of an accidental chemo spill, they would need to be able to properly handle that. So the population that comes to mind most for me when I think of needing to be careful is this population of patients that may not be able to handle or understand the ambulatory pump. That being said, FOLFOX is a good regimen as far as you can do a lot of dose adjustments. So patients with extensive cardiac history are still able to get FOLFOX with certain modifications. Patients that might have hepatic considerations, things such as that, the provider would be able to do dose modifications. So FOLFOX really, it's a big population of patients that can tolerate it. Elderly patients can also tolerate it with certain modifications. Another population of patients that would need to be carefully considered would be patients that have significant peripheral neuropathy before starting FOLFOX. A provider may decide that a different course of treatment might be best for them.
Okay, thank you. Those are definitely good things to consider, especially when you are sending someone home with a pump, like you said, and being able to understand how it works and just what to do and troubleshoot, as you said. So talking about that, what are the safety concerns then for the patients and providers with FOLFOX? I'm sure it's different for patients versus providers, but what are some of those safety concerns?
For providers, when I say providers, I'm talking infusion nurses or people that are touching the patient while FOLFOX is infusing. So safety measures, proper handling and storage and dispensing of chemotherapy need to be followed. This would be the same as with any chemotherapy agent. Staff that are administering or handling or preparing should all have proper use of PPE, and infusion nurses should hold a current ONS chemotherapy provider card. The RN who is infusing needs to be trained and competent on a vascular access device. So they need to know how to access the Metaport and properly dress it. The nurse needs to be trained and competent on the brand of the ambulatory pump. Again, because this is not just a simple infusion in the clinic, they're going home with an ambulatory pump filled with chemotherapy. Another safety concern, patient safety concern, is the patient of childbearing age? Does a pregnancy test need to be taken prior to each course of FOLFOX? Labs need to be a safety, consideration as well. Labs such as the CBC, a CMP, and tumor markers should be obtained prior to the start of FOLFOX and then monitored accordingly as the cycles go on. Other safety concerns with 5FU, as I briefly talked about, is does the patient have a cardiac history? And if, they do we need to do a dose modification? The dose modification would be off of the infusion of 5-FU, not the bolus, because the infusion part of the 5-FU is the pump is where we see the cardiac side effects. And those would be such things as angina, that's the most common, an MI, heart failure, arrhythmias, EKG, all those side effects have been noted with 5-FU. So that would be something for a safety concern. And again, as I mentioned, provider could do a dose modification. Another safety concern as FOLFOX cycles go on is bone marrow suppression. Again, as a CBC is followed, if the patient needs to have growth factor, that is sometimes added as the cycles go on per the provider. And then also, we'll talk perhaps more about this a little bit, but GI toxicities, mucositis. So when I think of safety, I think of all of these things that an RN and the care team and patients, the patient's educated, the RN and the providers are assessing the patients for these possible side effects. Also, hand, foot, skin reactions with 5-FU. And then with oxaliplatinum, we have neuropathy. We want to know if they have a history of having a platinum allergy. Did they have previous treatment and have problems with platinum agents before? Does the patient have neuropathy? Do they come in with neuropathy? And we're going to monitor that as they go along. So we're looking for all of those things safety-wise for the providers, from the infusing of the chemotherapy, and with the nurses and the patients, the education of possible side effects and the monitoring ongoing of these things.
A lot to think about, both the providers and for the patients and their families when you are getting ready to start someone on one of these regimens, that's for sure.
There is a lot of things to consider, but as you take care of patients with FOLFOX, there are common themes that you see. So definitely it becomes easier as you take care of these patients.
I'm sure it does. And you kind of get into a routine of the things that need to be considered and educating those patients and things like that. So how can nurses establish and maintain these safety measures with these regimens with their patients that are receiving this?
Knowledge is best. So studying the drugs, an infusion nurse, they know the history of the patient, as I mentioned. They know, based off patient history, things to look for, based off patient allergies, based off their, the infusion nurse is looking at historic labs. They're keeping an eye out for drops in counts, elevated counts, changes in CMP, tumor markers, and then the physical changes of the patients. And as I mentioned, the oncology nurse is always, using proper PPE and putting safety first and making sure they're handling the agents per their institution policy and ONS standards.
So I want to switch gears a little bit and talk about the adverse events. You mentioned earlier a little bit about how the regimen can be modified, if needed for patients. But what are some of the adverse events or infusion reactions that would be associated with FOLFOX?
Absolutely. So oxaliplatinum is a unique chemotherapy agent. It has a unique side effect or adverse reaction perhaps, and it has this cold sensitivity that comes with it, and numbness and tingling, pins and needles, some patients describe it. So when oxaliplatinum is infusing, up until 4 days after the infusion, patients can have the onset of this cold sensitivity. It is quite acute, and it can start during the very first oxaliplatinum infusion. A patient will be educated on this before the start, but they often forget because it hasn't happened yet. So they'll take that first drink of something cold and they'll get a burning sensation perhaps in their fingers when they touch the glass or when they drink something cold. And the sensation is in their throat and it will feel like pins and needles. I've had patients describe it as they feel like they can't breathe. They also have a component of anxiety because they've never experienced this most often before. So they'll feel like they can't breathe, although they are breathing. It is from the oxaliplatinum. So patients need extensive education on this side effect. For those of us that live in the Northeast and we're experiencing a very cold winter, we have to educate the patients on bringing gloves or mittens, scarves, hats to infusion with them so that when they leave, they're all bundled up and we are all now wearing masks, but prior to the mask days, we would have patients put scarves over their mouths. So when they opened the door after infusion, they did not get blasted with cold air that caused this cold sensitivity in their throat again. We do things like have them have a loved one start their car so they get into a warm car before they leave. Much education, and the education needs to be ongoing as these cycles go on because the sensitivity can increase. And then they need to be reminded that they need to do this at home because they'll go home and they'll forget. They'll open up the refrigerator and grab the juice or eat something cold, and it happens all over again. There is a quick learning curve. Patients do learn very quickly and remember, but that is something that is unique to oxaliplatinum. They do have ongoing sensitivity as treatments go on, but it does typically resolve at the end of treatment. Also with oxaliplatinum, you can have infusion reactions. Generally, this is after dose 7, we start being concerned that the increase of reaction could occur. So, we tell patients to let us know if they start having itchy palms and feet, as that could be a sign of a reaction. It usually starts, or I have seen that it starts with itchy palms and feet, and then the reaction will progress. Of course, at that time, the nurse will stop the infusion and follow his or her institution guidelines for managing a reaction and notify the provider. Oxaliplatinum, on rare occasions, a patient will have an anaphylactic reaction to the first dose, but that is very rare. It's usually after when you get up to around dose 8 or 10. With 5-FU, we don't typically see infusion reactions. It's typically well tolerated. Leucovorin, when you tell a nurse that it's a form of folic acid, they do not think there will ever be a problem with leucovorin. And leucovorin can be a little bit tricky. It's rare, but patients do have infusion reactions to that. They will get very red, like a red lobster. They will have itching. They can have a rash. They could have some chest pain and shortness of breath. The tricky part is leucovorin and oxaliplatinum are running at the same time. So the nurse will do due diligence to decipher what the patient is reacting to. Are they reacting to the oxaliplatinum or are they reacting to the leucovorin? And again, the leucovorin reaction is very rare, but it can happen. So I wanted to mention that on this podcast so that the infusion nurse would have, their eye out for that. Also, just to speak about the infusion nurse, they are amazing, the oncology infusion nurse, because they have the essence of calm and confidence to the patient, but they're always prepared to have a reaction. That patient starts scratching their hand, or they do their little cough, or they look like they might have a backache, and the infusion nurse is right at their chair side, often before the patient even knows that they're going to have a reaction. So oncology infusion nurses are just amazing.
It is amazing what this treatment side effects are. You mentioned earlier that it's, a frequently used regimen and everything like that, but the side effects of oxaliplatin are pretty severe. And when you see them happen, and for patients, when they come back in and tell you about it, it's one of those things that, like you said, there's a very short learning curve on that.
There is.
They learn that so quickly. And I'm also in the kind of Northeast, not quite as north as you are, but just remembering, oh my goodness, I'm going to my appointment today, and by the time I'm going to be out of there, the temperature is supposed to drop. And did I bring my scarf and my gloves and this and that? But not only that, and going back and forth outside, but like you said, just opening up the freezer and getting something out of the freezer, or, the refrigerator, or learning to drink from the tap when you really like a drink with ice in it. So
Right.
all of those things that, we do need to encourage and teach our patients and family members about is so important. What are some of the nursing interventions that are effective in preventing and managing these different side effects that you have found?
So I think really good teaching, when I say teaching with patients, it's not just the one-time teaching. Patients, especially with FOLFOX, they're dealing with having to learn about a Metaport, having to learn about the ambulatory pump, previous things we've talked about. It's information overload for patients. So the oncology nurse really needs to just re-educate, especially as the cycles go on, because as patients get used to their Metaport and get used to going home with the pump, the nurse has the opportunity to reiterate the information that the patient heard but doesn't remember, because they have so much to remember. So reiterating, management for if they're struggling with nausea and vomiting, or struggling with diarrhea, constipation, or the hand, foot, skin reaction, or perhaps neuropathy or the cold sensitivity, and helping the patient figure out how to live their life to the fullest with these side effects and manage them effectively. The nurse becomes just vital as the cycles go on to help the patient have good quality of life while undergoing treatment. I cannot understate that the nurse plays a key role in helping the patient just have good quality of life through treatment.
I agree with you. And that ability for nurses to help patients balance that and understand that we feel that is so important for them, when they are getting treatment, and they shouldn't ever hesitate to let us know what is going on, and that we can work with them and work with the rest of the providers to help them get through these treatments and still have good quality of life, and just how important that is.
Agreed.
So we've talked, so much about the safety issues and the adverse events and things like that. What patient and caregiver education is going to need to be provided by nurses for this? Because, as you stated, there's so many important things that they're going to need to know at home about their infusion, as well as the side effect management or the adverse event management at home. So what are the education pieces that nurses are going to need to just really impart to patients?
So the Metaport, use of the Metaport, or if they have a different vascular access device, what they're doing with the dressing at home while they're hooked up to the pump. Can they not shower would be one. Proper management of antiemetics, possibly proper management of pain medicine, management of either diarrhea or constipation, any skin issues they're having. Also, making sure the patients have the proper education for the ambulatory pump. They have a spill kit at home if they need it. They have the phone number or what they're going to do in the middle of the night when the pump is beeping, or on the weekend when the clinic is closed. Making sure they have all of those resources. They know how to get a hold of who they need to get a hold of to manage through the pump. All of those things will make the patient feel more comfortable going home with the pump. And what we find is that the patients, are nervous the first couple of times going home with the pump, but as they get more comfortable, they get into their patterns and they figure out what works for them at home with their pump and things like that. But having the resources that the patient needs, who to call, what to do, and how do I, take my PRN medications and things like that for the patient and their caregiver are invaluable.
Are there any special teaching tips or things that you need to work with these patients on when they're going home? And what I'm thinking about are, for families that may have small children or pets or something like that, because we have to talk about that whenever we're talking about oral medications at home that patients are taking. And this is something that they are going home with. So are there anything special, just specifically related to that you would tell people?
Absolutely. I would tell the listening audience that they're going to hear more stories that they will not be able to believe of things that can happen with an ambulatory pump. So patients need to be educated with their caregivers to keep their pump in the tubing away from all pets, farm animals, and children, because they can get themselves in a little bit of trouble. And also to be mindful and careful of their Metaport, because the patient is connected from their Metaport. They have tubing that from the Metaport, then there's usually an adapter and the tubing changes into a longer tubing to go into the pump. So there's some connecting stuff that is happening. The patient needs to be aware of the caregiver. They need to be aware of changing clothes and what clothes they're going to put on and how to feed the pump through the clothing and things like that, or wear button-up clothing. So those little hints that the nurse can give the patient and caregiver will help them navigate through that.
To be really honest, I never thought about farm animals. I was thinking more about the fact that when my dog runs past my computer and runs through the cord and almost rips the computer off of the table, so I was thinking about that when I asked about pets. But farm animals is definitely something that I guess we have to really consider. But that's part of that quality of life too that you were talking about earlier. And if you have a patient who that's their livelihood, or that they do live in an area that they have their own farm and they have animals that they're caring for that are outside, and just, the safety of that too. So
yes, we had one farmer and he was carrying 50-pound feed bags over his shoulder on the side that his Metaport needle was on. When he was connected to his pump, he dislodged his needle. And then last week in one of our offices, a goat ate through the pump tubing.
Of course, a goat would eat through the pump tubing.
How that happened, I do not know. But also, and on another serious note, is just how does the patient sleep at night with the pump? Do they put the pump on their bedside table? Do they have enough tubing? It's things like that the nurse can talk with the patient, because those are real things the patient has to deal with at home while they're hooked up to their pump.
Yep, such good examples. So I just have a few questions that I like to finish out my podcast with and ask you. So the first one I'd like to ask you is, what are some common misconceptions about FOLFOX?
Patients, number one, patients think they're going to get really sick because it's chemotherapy and they are connected to a pump. So for whatever reason, they think that they're going to get really sick. So we do a lot of education that this is manageable and that they'll manage through it, but they think that they're going to be sick in bed and can't do anything. So we like to educate them that doesn't have to be the case. Patients think that they cannot work. Unfortunately, we see younger people that need to go to work and they have jobs, and many people are able to work through FOLFOX and they're able to go to work with their pump. Not everybody, but there are patients that can do that. Patients think they're going to lose all their hair because we've used the word chemotherapy, where they just usually have hair thinning. So they're very fearful, especially women, and some men, that they're going to lose their hair. And sometimes patients think, because medical people use terms like it's a 2-week cycle, they think they're going to be hooked up to a pump for 2 weeks. So, medical nurses and providers need to use language that patients can understand, because they'll come really scared thinking that they have to be hooked up for 2 weeks. And then the last one is that older patients, for whatever reason, think that this is not the treatment for them. And we have many older patients that do just fine with FOLFOX.
So my next question is, what is something about FOLFOX that's not often discussed, but you wish people knew more about?
So I have 3 things. One is what to do when their patient shows up for pump disconnect and there's leftover 5-FU in the bag. So it doesn't happen often, but pumps malfunction, things happen. The patient accidentally did something and, there's leftover 5-FU. I like this question because it's some nurses that maybe do not have a lot of oncology experience might think it's okay to just give whatever's left over in a bolus, and it's not. It has to be, if the provider wants the patient to finish the dose, it has to be over slow infusion. It cannot be given in a bolus. So that was one thing. The other thing I wanted to mention is that patients sometimes first line will have FOLFOX, then they're off FOLFOX for a period of time. They might have advanced disease. the provider might put them back on FOLFOX, and providers and nurses have forgotten that they have had previous oxaliplatinum. So I want to just mention that if a patient's going back on FOLFOX, to please remember to educate the patient that they have increased risk of oxalate reaction because they've been previously exposed. And then the third thing, which is dear to my heart, is DPD gene mutation. And that affects 5% of the general population. It's a mutation that prevents the metabolizing of 5-FU. So it's the general population, 5%. So then it's rare in cancer patients. However, we have seen it, and these patients get sick really fast. So they might get cycle 1, they present maybe at pump disconnect or a few days after, and they have severe diarrhea, GI issues, nausea, vomiting. They might already start with, hand and foot skin reaction. And as soon as you're thinking this doesn't seem right, you need to ask the provider if they will consider testing for the DPD gene mutation. It's a simple blood test. It does usually need to be sent out unless you work for a large institution, and takes a little bit of time to come back. But there are patients that do have this mutation, and they have to be tested because they may not be able to continue with 5-FU.
Thank you for those 3 things. Those are great things for us to consider, and especially that last one with that mutation. I'm sure that's, not something that people might hear or think of right away, but when you know that and you can help and helps, stop that or kind of cut it off at the pass early on, that's probably huge for the patients.
Yeah, patients can die if they, if the 5-FU continues. And again, it is rare, but, throughout the country, we treat a lot of patients. So there are going to be clinics where they see these patients. And as soon as the experienced nurse is thinking this patient is too sick, that is the right time to think we need to test for this.
Yeah, good to know. Absolutely. So what are some resources for patients and providers who want to learn more about FOLFOX regimens?
So, direct the providers to the NCCN guidelines, and chemocare.com is a resource that my institution uses. We like the language for patients and caregivers.
And I just want to thank you for being with us today because this has been really very informative. You have a wealth of knowledge on this regimen and what folks need to know about that whenever you're administering this. And just in closing, do you have any final comments?
In a humorous way, you'll see a lot of crazy things with patients and what they can do with their pumps because they're people that aren't in the medical world. So be flexible, smile, and help the patients through as they tell you their goat chewed through their tubing, or they cut their tubing with craft scissors, or the cat chewed the tubing. Have a sense of humor and smile and help the patient get through, because likely once it happens for them, once they have learned from their mistake.
Absolutely. That's for sure. And you're right about at least there is something funny that comes out of it sometimes when you do hear those stories come back in, or, they do come back in and talk to you about what they did as they were on this treatment. So thank you so much for your time today and for your expertise in this area. We really appreciate it, Jennifer.
Thank you so much for having me.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review on iTunes or wherever you download your podcasts. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org.